Afternoon or good morning, depending on where you're joining us from. Thank you for joining the Indian Health Service COVID-19 Clinical Readiness and Patient Care Teleeducation session for July 23rd, 2020. My name is Sean DeAndre. I'm the Chief Clinical Consultant for Emergency Medicine for the Indian Health Service and a staff physician in the emergency department in Fort Defiance at Sahotso Medical Center. This week, we're going to be talking about telemedicine and different approaches taken during the COVID-19 pandemic. And we're very fortunate to have firsthand experience from our colleagues at Chin-Lee, Dr. Eric Ritchie, who's the clinical director at Chin-Lee, and Stephen Neal, the chief of staff, a physician assistant who works with informatics at Chin-Lee. There will be plenty of time this week for a Q&A as we don't have Dr. Irlu joining us this week for a clinical update. He's having a well-deserved break. So we invite your questions throughout the session. And then we will be closing out. A couple of quick reminders. Please submit questions on an ongoing basis through the Q&A feature of Zoom. That can be found at the bottom of your screen. We'll do our best to respond during the presentations. There will be a post-session evaluation for which CME credit will be made available, so please go ahead and complete that. That survey, a link to that will be provided in the chat feature of Zoom. The session is recorded and your attendance serves as consent to be recorded. The recording will be made available for distribution following the session. And for access to the presenter's slides, please see the original ECHO announcement. I'll go ahead and stop my share, make it available for our colleagues in Chin-Lee. A couple of quick announcements before we get started. HHS very recently released a telemedicine teleeducation session that we will be sharing information for how to access that in the chat feature. So keep an eye out for that. If telemedicine is of interest to you and something that you're involved in, there is an 8-part series recently made available through HHS. And next week on the clinical readiness session, we will be talking with Dr. Nomi Levy-Carrick from Brigham and Women's Hospital about mental health sequelae of COVID-19, both for those who have been affected as well as caregivers and community members. So a quick teaser for next week. Now, moving on, I'm going to turn the call over to Dr. Ritchie and Stephen Neal from Chin-Lee to share with us their experience with telemedicine and what approaches they've used during the COVID-19 pandemic. So these colleagues are my neighbors just down the road. Thank you both for joining. We look forward to hearing about your experience.
Hey, thanks for having us, Sean. It's great to be here. My name's Eric Ritchie. I'm a physician and the Chief Medical Officer at Chin-Lee Hospital in Chin-Lee, Arizona, and I'll let my colleague Steve introduce himself.
Good morning, afternoon, everyone, wherever you may be. My name is Stephen Neal. I'm a PA, and I am the Chief of Staff at the Chin-Lee Service Unit, and I also work in informatics as well. So thanks for joining us.
Yes, we're going to talk a little bit about how we use some telemedicine platforms and some innovative and kind of novel ways to help us with our response to the COVID-19 pandemic. And what you're going to hear over the course of this presentation is that we had to overcome a lot of challenges to telemedicine implementation at Chin-Lee, especially when it comes to limited bandwidth and limited internet connectivity in our service area. And so some of the traditional ways that we thought we might implement telemedicine actually changed over the course of the COVID-19 response as we realized other valuable ways we could implement this technology. So let's go ahead and dive in. So in our outline, you're going to hear about some of the challenges we faced to implementing telemedicine at the beginning and some of the reasons why we were not using a lot of telemedicine pre-COVID. And then we're going to take you through 4 short stories of different ways in which we took telemedicine platforms and applied them to help with the COVID-19 response. Some of those are going to be in-house and some of those are going to be connecting to patients in the field. And then we'll share some future directions where we think telemedicine could go next for Chin-Lee, and then should have plenty of time for questions and answers afterwards to have a little bit more discussion.
Thanks, Eric. So in early April, we received a request from IHS was looking to go enterprise-wide with the Join.me telemedicine platform that they have. And before they launched it enterprise-wide, they requested that Chin-Lee be a test site. And so we were a test site. We, to just get as many tests as possible and maximize our potential of trying to break it, just really pushing it to its limit, we opened it up to our entire medical staff, our optometrists, occupational therapy, physical therapy, pediatrics, family practice, internal medicine, diabetes educators, and dietitians all participated in the test, which was pretty valuable. Made a good spreadsheet and just documented our findings along the way. And we learned a few things about Chinle. So this is from the FCC. You can embed and layer the available amount of FCC broadband licenses that are available for cellular providers, meaning that they're on the Navajo reservation and other reservations, as you can see on the map, there just isn't a lot of broadband cellular bandwidth options available. Dark red means there's a lot, and it goes down to pale orange where there's few. And then when there's none, there's none. So this is another map that just shows some of the challenges of telemedicine, or of broadband actually. Lighter green shows the number of broadband service providers. If you see in the top right corner of Arizona, that's Apache County, and that's where Chinle is. So we're one of the lower amount of broadband providers in the country. We only really have 4, but it's satellite, DSL, and fixed wireless, which is through the cellular bandwidth. End users effectively don't have sufficient bandwidth, and it's a significant limitation to telemedicine when you don't have internet. So our patients also have variable amounts of comfort with technology and variable in their end user equipment. A smartphone that's $20 from Walmart is not exactly capable for telemedicine. Other issues that we had to deal with are just infrastructure. Our call manager is actually not able to house telemedicine. So we send all of our telemedicine calls through IHS Aberdeen in South Dakota. And so we are actively looking to upgrade it, but working with the IHS video admins was really helpful. They were excellent. Brett and Dave were critical to the success of this project. The other issue is just staffing and workforce and infrastructure as a whole. This is a data point of IHS facilities are on average 40 years old. I think you can extrapolate that to other areas as well, but we just need to bring our infrastructure up to speed. This data point I thought was really, really telling. 0.16% of Apache County has access to 25 megabytes per second. The next lowest in Arizona is La Paz County with 51%. So Apache County and the Chinle area in particular has very little internet. So Eric, I'll let you.
Onto that background, I just want to take everybody back in time for a moment, a few months, and think about what it was like at the very beginning of the COVID-19 pandemic on Navajo Nation. Towards the end of March, we had our first case of community spread on the Navajo Nation. There was a lot of concern that the outbreak was already spreading out of control on the reservation. And we had to rapidly modify our clinical services like a lot of other clinics and hospitals had to do. And that includes shutting down a lot of our routine outpatient services and trying to move as many non-urgent, non-emergent business as we could to telemedicine platforms. But like Stephen shared with you, most of our patients in our service area just did not have reliable internet access. In fact, a lot of our patients don't even have telephones. And so reaching these patients with those platforms is proving challenging. So we had this tech on hand, we had equipment, we knew how to use it, but we couldn't reach our target audience in a traditional way. And so we had to start thinking, how can we deploy this technology in a way that helps the response, given that using it to reach patients at home is not really an option for us right now.
Right. Yeah, we had been preparing to launch our own telemedicine clinic, and we were, the estimated launch date was in the summertime, about now. And so we had purchased the equipment, got it registered, licensed, and brought on to the South Dakota call manager, but ready to be used in Chinle. And then, so we were plug and play ready to go, which was really critical to the success. So we had the equipment, we had the platform, and then we had this response and these problems that presented. We launched our respiratory clinic. March 22nd is when it converted to telemedicine. The emergency department early to mid-April. We don't remember the exact date. Everything was kind of blurry at that point. Nephrology clinics was early to mid-April as well. And then we have an ongoing tablet pilot program that we'll discuss a little bit.
Yeah, so again, still in our time machine at the beginning of the pandemic, like many other facilities, we were rapidly trying to adapt to the new normal of having to take every patient that had any kind of respiratory symptoms or exposure at all and care for them in an outdoor environment and try to test them and screen them and rapidly discharge them. And at Chinley in particular, we were just experiencing a flood of worried well patients who wanted to be evaluated for possible COVID-19. And because there was community spread in our area, if any of those patients had symptoms, we really had to treat them as a possible case. And so over on the right, you can see a few pictures there. There's a kind of a low-res grainy picture of our outpatient entrance. This became the single point of entry for the whole hospital. So ED patients, outpatient appointments, people coming to the pharmacy, anybody that was entering the building were funneled through this single entrance so we could screen them. And if they screened positive for some of their exposure, we were actually turning them away at the door and saying, no, we want you to go over this outdoor screening area. And we had set up the only tent we had at the time was our flimsy little decon tent that was set up outside that entrance. And we brought our mobile health unit over to try to assist with this flood of patients that were going through this outdoor screening environment. And it posed a lot of challenges for us. It was quite cold at the time. And so we actually had issues with even equipment like vital sign monitors not functioning properly and giving inaccurate vital signs. Documentation was a huge issue for our providers because they were having to sort of go to a patient in their vehicle or on the sidewalk and then come back to another area to document. The patient flow was not very scalable. So what ended up happening was at different times of the day, we would just have patients piled up outside trying to get through this outdoor screening process that just ended up being really clunky for us. The other thing that we had visibility on really quickly is we realized that we were burning a huge amount of PPE in this environment. And that was a problem for us because we knew that the hospitalizations were coming. And we knew that it was going to be hard for us to reload on PPE, but we were burning through gowns and masks and gloves just seeing these not that sick patients outside. And so we needed to make a change and find something that was going to work for us. And that was when Stephen and I looked at each other and said, hey, we're using this telemedicine equipment right now to try to reach the non-COVID patients at home. Maybe we should be using this equipment to care for some of the COVID-like patients here to limit the exposure to our staff and conserve PPE. And so that's what we ended up doing with our respiratory clinic. So what we were able to do is, and Steve, you can go to the next slide. We were able to take an isolated area in our outpatient building, cordon it off, make it a respiratory isolation clinic solely to care for these low acuity patients that were seeking evaluation for a COVID-like illness. And we were able to do 100% of these visits on telemedicine, which meant that we didn't have to expose our providers to these patients, and we were able to conserve PPE by not having face-to-face encounters with all these patients that really just needed a rapid screening exam and a COVID test. So patients in this environment, everyone's masked, there's no aerosol generating procedures taking place. It's completely isolated from all of our other care environments. And it's very easy for us to separate the flow of patients entering the facility from ones that need to be screened for COVID versus patients that can come through and go about their business for other outpatient care. Or go to the emergency department. It solved our problems with climate control. It solved problems with weather and documentation. And it allowed us to be able to identify some of those sickest patients and get them to the ER really rapidly. Whereas in our outdoor environment, we had patients that were waiting a long time and were not necessarily getting a really accurate triage because of some of the issues we were having functioning in inclement weather. So Steve will talk a little bit more about how some of the technology worked on the next slide.
Right. One of the values is optimized space utilization. All of our outpatient clinics were closed, and so we had computers and rooms, but couldn't really get patients in and out. So a patient would get sat in this room right here with the hexagon, and a DX80 is that device. They would sit down in the chair, the door would get opened by the health tech, they would sit down in the chair, and the device would actually auto answer. So this is a nurse practitioner right here that was just beaming into the room, and the device just turns on. And so the patient literally touches nothing but the chair, which is pretty valuable. Turns on, and ultimately what we did is we just left the device on. We created a meeting and we just sat in that meeting, and people would just get sat down, and we would just rinse and repeat. A lot of providers were hesitant to see COVID patients. Many of them are higher risk due to various reasons. This gave them that ability to participate in the response and protect them and the patients as well. Patients, we didn't get a single complaint from any patient about telemedicine, because you always want to consider the cultural component of talking to a screen, and all the patients were actually ecstatic about it. I mean, maybe not ecstatic, but they were pleasantly pleased by not seeing a provider in person, which is a critical component. Early on, I'm sure as the response was picking up, or as people started to get caseloads increased in the very early days of the pandemic, quite a few providers were quarantined for various reasons. We haven't had a provider quarantined in months that I'm aware of, and it certainly has. I think that this respiratory clinic has helped contribute in the lack of quarantine providers. As Dr. Ritchie mentioned, the PPE burn rate was pretty critical. That was, at times it was crisis level on our PPE. So that really helped out. And then Dr. Ritchie also mentioned that the volume of people that we're seeing, I mean, if we would have let these patients go straight to the emergency room, it would have overrun our emergency room, and it would have really affected care. And then another point that was incredibly valuable is all of our providers are ready for telemedicine now. They are competent in working with the Join.me platform, and they feel comfortable integrating or just interacting with patients in a telemedicine platform, which is, not a small thing. That's actually pretty valuable. I'll let you address this, Dr. Ritchie.
Yeah, thanks. So yeah, one of the things that Stephen was pointing out about that high throughput environment was that it got providers really comfortable with telemedicine really quickly. When we were trying to use it to deploy to patients' homes, what we'd find is that it was so rare to find a patient that could maintain an audio-visual connection from their home that providers might do one telemedicine session a clinic. And in this situation, they did 20 in a row. And so they got really facile with it really fast, which is very valuable for us moving forward. The other thing that this environment allowed us to do is to be able to track the number of patients that were coming through needing an evaluation for COVID-like illness. So our productivity, if you will, or our volume in the respiratory clinic became a surrogate for the number of patients with COVID-like illness that were coming through the facility. And you can see our volume was quite high during the days where we were experiencing a surge of patients, and now has come down to a more manageable level in June and July, which is totally consistent with what our epi curve on COVID cases looks like. So this became another surveillance tool for us. When we saw respiratory clinic volume spiking, we could anticipate that there might be a spike in cases coming our way as well. You can go to the next slide, Steve. The other thing that this environment did was, because it was rapid throughput, it was designed with patients in mind, and patients were comfortable in this environment, and it was open 24/7. It allowed us to facilitate a really high volume of testing here at the hospital and sustain that over a long period of time. So the blue line on the left just shows how rapidly our testing volume increased over time, and how we've been able to sustain an average of about 130 tests a day over the past 4, 5, 6 weeks using this quick in, quick out kind of model. And one thing we didn't point out earlier is patients aren't tested in that environment. They get a rapid screening exam with a telemedicine provider, and then they go outside to be tested. So that's how we get around the aerosol generating procedure part of this. So that's, and then the graph on the left is just showing number of tests per capita, Cheney Service Unit leading the nation with over 33% of our user population having access to COVID-19 tests at this point.
Yeah, testing was a huge success story. This is sort of for this audience in particular. One of the ways that we communicated to everyone is through OneNote, which is one of the, bringing on new systems to IHS can be cumbersome, and this was already there. And so this is actually one of the early rough drafts of it, but we created a OneNote page that was on our public share drive, and we had a hyperlink in our EHR. So providers, anyone that had access to EHR could just click a button and be taken to this page. And it was just incredibly useful to, as the testing protocol changed almost daily, depending on our testing supplies, depending on what tests we had, what types of tests, the billing, the charting, the numbers to contact, to be able to call the ER nurse quickly and get that number if you're a locums provider that's been in respiratory clinic for day one, and this is your first day on site. You don't have that information readily available. Schedule. So this was actually a really valuable tool that I think the rest of IHS could apply if they thought it was useful as well. It was basically just a simple, straightforward tool with different tabs, and then there's there are actually sub-tabs here that go into greater detail. So I thought that that was a valuable tool that we used.
Yeah, this became, like Steve said, it became a great way to communicate changes in real time. You talked about like the testing protocol. A lot of us were tweaking our testing protocol almost daily at the beginning. It was very easy for us to just update the OneNote, and then we knew for sure the providers that were over there in respiratory clinic ordering the test had access to it.
We didn't have to bombard email anymore.
Right, right. So we're going to shift gears now and go to our second story, which is about how we apply telemedicine solutions in our ER. And the challenge in the emergency department was different than the challenge that was posed by this flood of worried well patients. Here, our biggest problem was really the sicker patients that were going to require intubation. And you'll see in the upper right-hand corner there, that picture of one of our trauma bays, which is totally open environment, just separated from other places by curtains. This is where we would traditionally care for a critical care patient in the ER, right? Normally your goal if someone's getting really sick is to throw open the doors, have good line of sight, have closed loop communication with people in other parts of the ER, bringing in the medications you need, the supplies you need, somebody keeping track on a flow sheet. None of those things were possible when we had to intubate a COVID patient because it all had to happen behind closed doors with masks on. And so that posed a real challenge to the normal flow in the emergency department. You'll see the picture in the little hexagon is one of our isolation rooms in the ER. So we were lucky because we actually had 2 negative pressure isolation rooms in our emergency department already. But they're small and cramped and don't have a good visibility. Some of them didn't have any windows. So it was really difficult for someone that was inside this room caring for a patient to communicate with someone outside without opening the doors, potentially aerosolizing COVID in the emergency department, and having to don and doff PPE each time they go in and out of that room. And so there was a possibility for a solution there, and Steve's going to talk about how we deployed some tech to help.
Yeah, so on the wall right here is an actual DX80, and these are actually, our computers used to be there where we would chart, where someone in the room would chart, et cetera. And so we just removed that because people were in PPE for long periods of time in the room, and we put the DX80, we just mounted it to the wall, and it happened to fit the mount. It's a standard mount. And then we have an 8865 here where it's literally 3 to 4 buttons that you push, and depending on if you're calling room A or room B. And so you push those 3 buttons and then boom, it auto answers and turns on. We were able to see, 301 patients were roomed into these 2 negative pressure rooms between April 15th and June 30th. And those rooms were particularly reserved for COVID persons under investigation and intubation. So those are all higher risk patients that we put in those rooms. So it's a decent volume of patients. The ability the ER staff could look at both rooms at the same time, or they could jump from one room to another quickly. So it was facile in its ability to just move around, and all without wearing PPE. And the ease of use was critical for the ER. I mean, the ER is just it's a busy department and there's a lot of moving parts. Being able to have pushed 3 buttons and have it done was pretty valuable for the staff at midnight. For a new staff that just came on at midnight. This is actually an article in the Journal of American Academy of Physician Assistants of New York Presbyterian is actually using telehealth as a medical screening exam for their ER now. So we kind of beat them to it, but I think there's going to be a growing trend in this area, or there very well might be. So.
Yeah, great. So the third story we're going to tell is about our outpatient specialty clinics. And this was kind of an interesting environment. You heard during the part about the respiratory clinic, one of the things we learned from our respiratory clinic patients was that some of them were actually scared of seeing a provider. They were actually more worried that the provider was a vector for COVID-19 than they were necessarily about some folks that were in the community. And in our specialty clinic, we had an environment where we were very reliant on, in particular, traveling physicians, because most of our subspecialty services aren't high enough volume here for us to have dedicated specialists on site. So we often have people that travel in from other places to provide services, and that causes an extra layer of risk. Now, some of those clinics we were able to cancel or postpone, but nephrology is a special environment because these are really high-risk patients that the nephrologists really need to see every week, and they needed a way to do that. We already established we couldn't reach those patients at home. They were going to have to come to the facility one way or the other, and in many cases, the nephrologists were already on site because they still had to go provide care at the dialysis center that was right next door. But the patient-provider interaction was the part that we were worried about. And so we needed a way to facilitate that so that the patients felt safe and could still get the care that they needed. And the providers felt like they could continue to have access to this patient population.
Yeah, so the setup of the nephrology clinics, we had 3 different nephrology groups, 7 nephrologists in total. We got them a VPN, trained them in the telemedicine platform, advised them and gave them support. And it was functional and operational within 10 days of starting, so it was rapid. We had great support with our specialty clinic. They were really valuable. And an interesting point about the equipment in particular. So our DX80s and our 8865s, what you saw in the ER in our respiratory clinic, we ran out. We didn't have enough. So for this clinic, we just set up an all-in-one computer. So it's a desktop PC with a microphone and camera. So the telemedicine equipment is just a computer. And so we just put this into the specialty exam rooms and did telemedicine visits with with the nephrologists, who some beamed in, like Dr. Ritchie said, off-site, and some were actually on-site because they happened to do rounds at the dialysis center, but we just kept them, they're in a different room, and sometimes in the next room over, doing a telemedicine visit, so it's kind of interesting, so.
All right, and then the last thing we're going to talk about today is how we did try to reach some of our highest risk patients at home and tried to overcome some of those challenges of bandwidth that limited our ability to reach them on their own native devices. And the patients that we wanted to focus on were the ones in our high risk primary care cohort. We have a program here at Shinley that we call Bahojo, which is specifically for patients that have complex needs and multiple comorbidities. And these were exactly the kinds of patients that we did not want to come to our facility during this time, but they were exactly the kind of patients that we most needed to reach and continue to provide care for. And many of them were high risk because they were in areas that didn't have electricity and running water, or they were difficult to reach at baseline. Some of them were difficult to reach over the telephone even. So we had to have a way to do frequent follow-up visits for these patients without bringing them into the facility, and do it in an environment where they have poor connectivity at baseline.
IHS actually reached out to us and sort of generously offered us the opportunity to test and create a use case scenario. And this is what we applied it to. We took 2 tablets that tap into the FirstNet. It's a first responder network of cellular. So you tap into the cellular broadband, and you actually get priority on the cellular broadband when you're with FirstNet. It's available to all of IHS. So when whoever goes to put any of your cell phones or any of your devices on it, there's actually an agency-wide, you can talk to, I can't remember her name, but someone in Albuquerque actually knows this very well. So there's a process to do it. And then we would just have the PCP or the patient beam into the PCP on the PCP's admin time. And so the PCP knows who these patients are, understands their health problems. And we had a Navajo Nation, it's actually not a CHR, it's a health promotion person, Valerie is her name, and she's right there. And she has the actual tablet in her hand, and the tablet is designed to where it only goes to very limited website access points. One of those website access points is the Joint.me platform. And then we also created a SurveyMonkey just to gather data on how it's doing and how patients are feeling about it. And so far the results have been really promising. Patients have found it to be very useful, very effective, and the providers have as well. You know, it's a bit of work and coordination, but you know, it's been valuable to get patients seen, especially high-risk patients.
Yes, this was really great because we were able to go to our providers and say, who are the patients you're most worried about that you can't reach on the phone right now? And then we could take that information to folks with Navajo Nation and Health Promotions who knew exactly where these patients were, and deploy the tech to them. So you kind of heard about ways that we brought the patients to the tech in the building. You heard about how we brought the tech to the patients. And so then where does it go from here? And our hope is that as we start to move past the COVID-19 response, the lessons we've learned here about how to overcome limited bandwidth can be applied to other types of telemedicine solutions. You know, the tablet solution that you heard Stephen talk about is very scalable. It's easy to acquire these devices. They're low cost, and we can actually leverage the existing network of Navajo Nation CHRs to deploy more of these in the field to reach more of these hard to reach patients. The point-to-point variations on telemedicine that you heard about in our specialty clinics are easily applicable to other internet access points that are just beyond our facility. So if we start with making these connections within the building, then the next step is, well, why don't we take this to an internet access point at a chapter house or a senior center or another place in the community so the patient doesn't have to travel as far. And then lastly, with specialty services, we are able to beam in nephrologists. The next step is going to be, can we beam in other types of specialists that would normally have to travel here to see patients in person? And the great thing about all this is that we now have a whole staff of providers and support staff who can create a Join.Meet session in an instant, who know how to set this up but are now interested in moving it forward. And so that's been the real success of doing this on site.
Yeah, and if you look at, I've taken a look at other regional medical centers in Arizona, and there has been a couple similar size, similar volume institutions have implemented tele-ICU and tele-stroke centers, and they've had a return on investment, decreased length of stay in their hospital, and decreased mortality. And so I think those are areas that we can certainly entertain, and one of those facilities actually uses the Join.Meet Cisco platform, so it's very similar to what we use. It's the same, actually. Other areas are sort of send the tablet home with people for lactation and hospice. You know, those are, our lactation rates could be better, and this is an area that we could definitely improve those. Hospice doesn't exist where we are on the reservation, and I feel that it doesn't have to. I mean, it can, and this is a means to do that. We've considered outfitting the emergency medical responders with tablets in the field so they can, you know, some of those sort of soft cases of like, do we need to bring this patient in? They could just beam in and have a visit. And it actually, for Arizona, would qualify as a visit. It actually is billed and appropriately categorized as a visit. So
and even as a medical screening examination.
Exactly. And so it's done, you know, in the field, and you know, there's a limited resources of emergency responders, and therefore you're just flexing that more appropriately, and they can go to calls that are more, it's just more efficient. And so this is something we're looking to do in the future. Before we do any of that, we kind of have to take a good analysis of our staffing, and just make sure that we have the appropriate staffing, motivated opportunities to keep growing. We actually, Chinle technically had a telemedicine platform with Global Med, like around 2010-ish. It never fully became actualized for various reasons. So we got to see it through and make sure that it's a team-based approach. Infrastructure, our call manager is currently not able to accommodate the telemedicine that we would like to do. We're working on that, and we're updating that. And then just data-driven, you know, as much as I would love to have a neurology clinic for specialty services, do we need that? Well, I don't know. We have to evaluate it and just, you know, use data to drive our decisions.
Yeah, so in summary,
go ahead, Eric. We've sort of discussed that we have limited poor quality broadband. I think we hit that one pretty hard. And the cost versus benefit for our patients is just not there. Having point-to-point on-site has been a great solution to meet our needs during the COVID pandemic, and we've discussed the conservation of PPE. Eric, do you want to finish up the slide? That way we'll share it.
Oh, sure. Yeah. So we limited exposure between patients and providers, which was actually a win for both sides. It was a concern for our patients and for our providers. In places like the emergency department, it actually made the communication better, and enhanced the efficiency of the visits, and made them quicker. We were able to leverage equipment that we had already purchased and didn't know what to do with or couldn't use successfully in a traditional way. And like we've already said, our providers are now expert users of these platforms, so the potential to scale is there. So yeah.
And remember, distance prevents, including telemedicine. I love the two sheeps. I think that's the best poster ever. So, and we're open for questions, and we've got a decent amount of time. So really, any questions? I'm sure there's some in the chat.
There are indeed. Thank you both for a wonderful presentation about, I'm just a little bit dizzy by how much you all accomplished in a short space of time, knowing how much has been going on for all of us. And I think while you started off, and I want to start with a question about the tech baseline of this, which you led with, I think rightly so, the limited bandwidth in the region that the three of us all work in, yet the proof of what can be accomplished is in this presentation. So you overcame what I think for what many of us seems to be the biggest barrier. We do have questions. We've also got Captain David Wong from Albuquerque, who we're fortunate to bring in the conversation here in a second. But just going back to that first slide, or second, one of the first few slides about that bandwidth issue, can you break it down for some of us who are a little bit, I'll talk about myself, a little bit less tech inclined. When you talk about the speed, yet the tablet program worked with the cellular data. Was that what overcame the bandwidth issue? Was that the kind of secret sauce there?
Yeah, no, I can expand upon that. So broadband options in the Chinle service unit area and Apache County as a whole are either satellite DSL or fixed wireless, which is cellular broadband. So satellite has latency, so when you click, you have to wait a half second for anything to take place. It's also expensive and you have to buy long-term contracts. DSL, the further you get away from the source, the less it works. It doesn't work as well. And so the quality diminishes rapidly as you go away from the institutional source of wherever that comes from. So the only other option is fixed wireless, which is where we basically use cell phone data and we tap into that. Now, we've actually tried this with just cell phones, and like as many patients that do, when we were doing our pilot of telemedicine that IHS requested that we test, a lot of patients would use their cell phone. And so we were actually doing that and it didn't work very well. It's the FirstNet that really improves that, because then you get priority access to the cellular bandwidth towers. And so you're able to do that much more reliably. You know, I think we've done probably close to 15 tablet in the field visits. I think one didn't work. We just couldn't get it to work. You know, maybe 2 other ones, the audio went out, we just restarted, kind of control deleted it, and it worked. And so, and they're pretty remote. These patients are out there, and it's worked really well. So does that answer your tech question, hopefully?
I think so, and I think it also answers Nathan Adson's question as well. His first question was, what video conferencing platform were you operating off of?
Yeah, so it's a Cisco, it has a bunch of different names, but telepresence is kind of what it's called, but it's an IHS platform that is available for at least federal, I'm sure for 638 and other facilities in IHS as well. And it is completely secure, it's encrypted end to end, and it's free and simple to use. It's been a fantastic platform, and IHS is lucky that the IHS video admins have been working on it. The Cisco web meeting, WebRTC, I think someone just pasted it in the chat. Dave Jansen did, who is incredibly, the IHS video admins were really helpful, and they put a lot of work into this. I mean, this is a multi-year, multi-million-dollar project that has just come about at the right time where we're able to capitalize on it. So we're really lucky to have that because it doesn't have the issues that, although Zoom and other platforms have ease of use, this one I would argue is just as easy to use, but it's completely secure and house owned. We own it completely end to end. So
that's great. Thank you. There's a lot of questions starting to pop up, but I did want to introduce and thank him for allowing us to put him on the spot, bring him into the conversation, Captain David Wong, who's a pediatrician by training, though currently deployed as the ambulatory team lead on the COVID-19 Healthcare Resilience Working Group, which is part of the Navajo COVID-19 response. By the way, his day job is that he's the Chief Medical Officer for HHS Office of Minority Health. So that tells us a bit about how busy your schedule is. And so thank you, Dr. Wong, for taking time to join us.
Yeah, sure. Thank you so much. It's great to be here. And, you know, as you said earlier, I'm currently based in DC, but I previously lived in New Mexico for 12 years and did a lot of work with tribes, including Navajo Nation. And so it's always a great opportunity to engage more with Indian Health Service. So thank you for the opportunity.
Thanks again. And you may have, actually all 3 of you may have comments about this question. Chantel Bowman was asking, how do we get this up at other IHS sites? And there's probably 2, different ways to break this question down. One, I think the more big picture, higher level approach, Captain Wong might be able to comment on that, but then there's the more granular step-by-step process. How do we do this? Which we could probably hear from Chinle about that. So I don't know who wants to take a swing at that one first.
Yeah, so the Cisco Join.me platform that Stephen's been talking about should be available to anyone at an IHS facility already. And so the major challenge to implementation, I think, is going to be acquiring hardware and then training people to use it. And the nice thing about some of the things that we did is that platform can be used on any computer with a webcam. And so if you look at what we did in the nephrology clinic, for example, there's no special hardware there. Those computers were already there. We just put webcams on them and then pointed them to the correct website. So I think there's actually the ability, especially if you're going to do some of these point-to-point things, there's actually the ability to adopt pretty rapidly. And then, some of the fancier equipment like the DX80s and the 8865s, those are really nice for some of those settings where, like Steve pointed out, the kind of no-touch thing that's really nice for patients when either the patient doesn't want to touch anything in the exam room or you don't want the patient to touch anything.
Right.
And then the 8865s were really great for some of the busier areas like the nurse's station in the ER, or we've deployed them to our COVID ward as well. So those 8865s are now the phones in the nurse's station are our COVID ward. So the nurses can beam in to those rooms without having to gear up and go in for an IV pull or some other routine call issue for the patient.
That actually got cut from the slides, but we've done on the respiratory care unit probably about somewhere around 60 intubations, and they were all sort of captured and documented and recorded via the 8865, the phone. It's a voice over internet protocol, a VoIP phone, which basically is how all of IHS sites are set up for their phone calls. It's a voice over internet protocol. This just adds a camera. It just adds the audio component. So a nurse was able to be documenting and recording what meds were given, blah, 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 when it was happening real time. And there's sort of an outside observer that's able to make sure everything's going okay. And if there's help is needed, then they're get help, able to get help.
Right. So instead of having that extra person in the room for that critical case, which is something we're used to, I think going back to what Dr. Ritchie was saying before, the way that we like to run a controlled critical resuscitation is much of that runs contrary to our best infection prevention practices. So what you're saying is you have that extra support, but they're behind the safe shield of the cyber connection.
Yes.
Yeah, and just to add to what Dr. Ritchie said, this really could be set up with just a all-in-one computer, a desktop computer. So where we put the DX80 on the wall, you could have a computer. It's a little less user-friendly, but it's very doable. It's quite possible. So just
that I think is a really key point and probably gets to the heart of what a lot of the folks asking, how do we do this? So it sounds like we don't necessarily need new equipment. We need to acquire the Cisco software that you're talking about, have some local expertise in using that and running it off.
Not even that. That's already there, to be honest. It should be. So all of IHS, I can't speak for 638 sites, but they should have a Cisco-based call manager, which is where all the phone calls are made. And so that system, or they can do as we are. If we have a call manager on site, we don't have the capability of hosting the telemedicine visits, so we route it through IHS video admins in South Dakota. So all of our telemedicine visits actually have a 605 number, a South Dakota number on them, which has worked great. And I think they'll be, maybe I'm throwing them under the bus, but they might be willing to help others as well. I think they will. And you log in via your D1. So it's completely, so as long as you have a D1, which 638 sites that might be a challenge because I don't know if they all have a D1. But you can log in and it's completely secure and it syncs with D1.
And I definitely encourage everyone who has these questions about how to set these things up, how to use this, to have a look at the chat, cut and paste what you see there, because David Jensen and others have been sharing some, I think, very helpful resources and links to additional resources. So go ahead and cut and paste if you have a chance there out of the chat. Captain Wong, did you have any thoughts about this from the higher level headquarters or HHS perspective as far as scaling up or scaling across the agencies, this type of telehealth program?
Yeah, well, the one thing I caught the tail end of the presentation, so I missed a little bit of the early part, but I really was impressed and intrigued with the presentation you gave about the FIRST Network and the iPads with the health promotion staff. I think that's really innovative, and I see a lot of applications for that, not just with other IHS travel sites, but really all rural communities in general. And so I'm just curious because I don't know, but do you know, is this a technology that's widely used right now in other rural settings, being piloted in tribal, or is this kind of new concept, for anyone?
Well, I can speak to the broadband capability through cellular bandwidth is not new. That's likely in many rural communities because that's likely their only access point other than satellite. Satellite and cellular are the only option for many places. Fixed cable or DSL is just, it is variable in its use in rural communities. So how many places are deploying a tablet to the field to tap in to that network? I don't know. I honestly, to my knowledge, we're one of the first, but I don't know.
Yeah, I mean, this is really exciting because I think Sean talked earlier about the telemedicine hack initiative that our team is leading as a national initiative. And at our launch yesterday, we had over 1,600 participants, and 49% are from rural communities. And many of them are tribal too. We didn't differentiate that in the survey, but this would be a wonderful kind of pearl. And we're calling them life hacks. That's how we got the name telemedicine hack, is life hacks for telemedicine, things that can make your telemedicine implementation experience easier and better. And I personally, this was brand new to kind of think about using that tool, having someone essentially bringing the internet to you on a very temporary basis to allow the telemedicine visit to happen. And then that pad can then be used for other patient visits. And I think that is a wonderful solution. I don't know how scalable that is. I don't know the cost. I mean, I know you're getting it right now from IHS headquarters. I don't, so there's some things that, we have to kind of think through, but I think just that seed of an idea is so brilliant. And I would love to see if there's an opportunity, and actually I know we have a call later today, to think about if you'd be willing to share that nugget and maybe some of the other ones too. Keep in mind for telemedicine hack, it's an ambulatory audience only. We have about, just to give you other data, it's about 70% primary care, 40% from private practice, either solo or group. And the top specialties are family medicine, about 30%, followed by internal medicine, about 12%, and then subspecialty, 7-8%. So, and we have peds as well, mental health, occupational therapy. It's a very diverse group from all 50 states, many territories in some countries. So anyway, it's a great opportunity, I think, to shine a spotlight on what you're doing. And just for the audience, if anyone in Echo Land is interested in joining Telemedicine Hack, it's a 10-week series, and we have 5 topical sessions followed by office hours. So each week, Wednesdays from 10 to 11 Mountain Time are our sessions. Yesterday was our launch. Our goal at the end is for 75% of all the participants to have implemented at least one video-based telemedicine visit and billed for it by September 30th. So again, we're getting the whole community ready for the fall surge that we all anticipate. We know that there's going to be more people staying at home. How do we continue to deliver that care? And we're doing this as a peer-to-peer model based after a lot of the CMS style learning collaboratives. You may have heard of Transforming Clinical Practice Initiative, Partnership for Patients. We're using the same tools. And the way those main tools are you have 2 case presentations with every session. We would love if you could do this, because this is exactly the kind of story would be really captivating the audience. And then in between the sessions, we're driving people towards discussion boards so that the people can then have comments and questions they ask of the other peers outside of the sessions. And this will go for 10 weeks. And so we're hoping with all that additional collaboration, the ambulatory community will actually lift itself up as one, as a unit. And tribal folks and IHS are obviously very critical to this. And I can tell you, having eyeballed a lot of the email addresses, there's a lot of IHS people on the telemedicine hack community. And so I really, we'll talk more later, but I think what you've done at Chinle is incredibly impressive, as Sean said earlier, and really inspiring, actually.
Thank you.
Absolutely. And I wanted to remind folks that I shared the link to the telemedicine hack or life hack again in the chat notes there. So feel free to copy that Echo link as well. And I think it's, what our colleagues have done at Chin Lee is, probably at one end of the spectrum of performance in terms of telemedicine. And I think I saw informatics in Stephen's title. So my suspicion is he's got some background in that. You may not have that at the site that you work at, and this may take a fair bit of institutional capacity development initially. And so I think this program that Captain Wong is referencing and putting on over 10 weeks is the type of assistance with developing our capacity that many of our sites probably need, because I don't think all of us have someone who's got a background in informatics or awareness in informatics. And this, what we're hearing about, my sense is this is just at the very front of the cutting edge. So I don't know that folks should feel the pressure to expand something quite as quickly as Chin Lee did, but we now see that there are resources to allow this to happen over a bit longer period of time, but allowing us to prepare, as Captain Wong said, for the what we expect will be a surge in the fall. There have been several Q&As. Thank you, Dr. Ritchie, for addressing some of the questions that have come up here. And there have been many questions. There have also been additional resources shared in the chat. So keep an eye on that chat as it scrolls through with additional telemedicine resource that you can cut and paste. There's a couple of questions coming up. Karina Teves asked, can 638 use another secure video session? And I guess the question there might be, do 638s have access to the same software that you're using at Chin Lee? Captain Wong, maybe you might know the answer to that.
Actually, I don't know the answer to that specific question. Maybe someone else does.
David Jansen might be the one to answer that. I can say that 638 sites and facilities have the ability to operate other telemedicine platforms as well. I don't know. It likely depends on sort of the specifics. If they're on the D1, then maybe they have access to the Cisco Join.meet, but some 638 sites are not. And so they're completely removed. They don't operate RPMS. So I think it depends is the answer for 638 sites.
So Karina is writing no D1 access at her site, and then David wrote in that, okay, it depends on the shares. So it depends on the negotiation between the 638 and IHS headquarters. So I guess the question is for those 638 audience members listening, if you don't have the D1 access, then I guess the question is, what would be reasonable and secure platform to use? And I know this is asking folks to move outside of what their experience has been, but Stephen, do you have any thoughts on what folks might reach for that would be HIPAA compliant and have the security assurances that are needed for something like this?
Right. So Zoom has a bad rap, but if you buy Zoom for healthcare professionals and you operate it in a secure manner, it is reasonable to do that. DoxyMe, I mean, there's quite a few that are encrypted end to end. I mean, even WhatsApp is encrypted end to end. And, 638s have a lot more leeway and freedom in what they do. I'm not necessarily endorsing any of them, to be honest, other than the Cisco Join.meet platform, because I think it is excellent and it's the only one I can use. The other ones, but if you were a 638 site, if you can use it, I would use it because it's low hanging fruit, it's ready to roll, and you can. Otherwise, I would just entertain and consider really anything that meets the appropriate encryption HIPAA standards, which there are many out there. There's quite a few now, and it's only going to grow. So I'm sort of agnostic about which one to use. Whichever works, and whichever is appropriate. DoxyMe, lots of people like that one. So as whichever one meets your needs. BlueJeans is fine too. I mean, there's a lot. So really, as long as it meets the appropriate criteria, talk to your informatics, talk to your IT department, and just make sure, and your privacy officer, people of that nature, because they're going to want to have input into that decision. So yeah.
Yeah, I was going to say convene that exact group of folks. Get your IT, your informatics, and your compliance or privacy or secure folks involved in that discussion. I think the HIPAA, as I understand it, the HIPAA regulations have been a little bit of a moving target. Some of those regulations with regard to telemedicine having been loosened, I would say go back to your compliance officer, your privacy personnel to make sure that we are complying with the most recent regulatory standards around that.
Right now it's open game with whoever, whatever, but
right.
That's not going to last forever. That's going to change. So
that's right. That's right. There was a question that came up about folks having tried to set up an internet access point at chapter houses, having difficulty with connection, and asking the Chin Lee team, do you think that the tablet solution relying on the cellular network could be a reasonable alternative to that for an access point at the chapter houses?
Absolutely. Eric, do you have anything to say on this?
Yeah, I typed in some answers that I was a little vague, but yeah, the FirstNet tablet definitely would work in that environment, but it doesn't have to be a tablet. And one of the things we've been experimenting with here at Chin Lee with our mobile health unit is bringing a mobile internet access point with us when we set up in the field. And our IRM team calls it a network in a box, but they essentially have a way to capitalize on relatively good cellular coverage in our area and create a mobile hotspot that securely connects back to our hospital internet, and we can set up an EHR session in that. We can set up a secure join.meet session, and then we could run even one of the bigger pieces of equipment out of a chapter house or a senior center using that approach if they didn't have broadband on site.
Yeah, the system that Eric is mentioning actually is within network, whereas the tablet is completely out of network. So it's not it's an IHS tablet in ownership, but it has no direct access to the IHS network. So it's a tablet that taps into the internet and taps into one website that is the join.me website. And so that's a good distinction of the two. What Eric is suggesting is that that's an IHS owned, operated, and functional network. So the network in a box, as we call it, colloquially I'll call it, you are able to chart, you're able to access the complete IHS infrastructure. It's been cleared and it's appropriately security allocated in case anyone's worried. But so they're slightly different. They are a little different. The tablet one is just the ability to tap into one website on the internet.
Yeah, and Steve's right. Depending on this is where we're exploring now. If we go to some of these mobile internet access points in the community, is you have to consider who's going to be staffing that environment. And if the people staffing that environment are IHS employees, then setting it up on the IHS network and using IHS hardware has some advantages. But if you're going to use an approach like we used with the tablets, where perhaps a Navajo Nation employee that's already on site is facilitating that, then the tablets might be a better approach because they're restricted, they're not on the secured network, and they're simple enough for someone without any technical training to be able to use.
Okay. So again, it sounds like that's yet another possibility and folks running into trouble with connectivity issues at the chapter houses, consider this tablet alternative for a lot of good reasons that you shared. It's striking. I think we're thinking and talking about telemedicine in a little bit different way than we have historically. We're talking about telemedicine use also within the clinics, within the hospital. And I just wanted to point that out that I'm struck that this is a new dimension of telemedicine that we're not used to talking about. We're used to the provider or the clinical team being many miles apart from the patient. We're talking about, you might bring them a matter of feet away, but because of the safety issues we're currently facing, you have those folks a few feet away, and then you limit your exposure just to the lab personnel possibly. And so I just want to remind folks that the definition of telemedicine is, I think, expanding before our eyes. We probably have time for one more question that came up, and I think everyone appreciates how throughout the IHS and 638 system we have really tremendous expertise, including specialists, though in fairly disaggregated format. So we've got a certain site may have a certain specialist that there's not another specialists like that for 2 areas away across the country. Is there a chance that you can see this platform being used to reach across within the IHS network? Typically, we're focusing on regional referrals, regional consultation, but is there an opportunity or utility here to reach out within the IHS network to specialists? Let's say maybe you're in Arizona and you're consulting someone in Washington State who doesn't exist in our region. Has that something that's ever been thought about or discussed from your side in Chin Lee?
I would say it's absolutely possible, and it would just be a matter of cultivating those specialists within IHS. I think one of the biggest limitations that our service unit has to subspecialty care is volume. And we just don't, for most subspecialty services, there's not enough volume for us to employ someone full time. But if those resources are pooled and there's a telemedicine center of excellence with full-time IHS specialists that can care for people at multiple IHS sites, it actually checks a lot of boxes. It provides access, it takes care of the volume issue, and it takes care of some liability issues that come up when you try to bring in visiting specialists for sort of one-off clinics. So I think it's a great idea and could be something that's scalable across IHS.
Absolutely. Yeah, we're in the process of making a standalone telemedicine clinic, and we're partnering with people that have either worked in Chinle in the past and have that skill set, and also, but to pool those resources and work with IHS as a whole, I think is something that leadership should look towards, because it would be an excellent opportunity. I know PIMC offers their teledermatology to everyone in the area around PIMC. We're likely going to capitalize that on once we get the Afghan asynchronous system set up on our site. But why couldn't we do that with cardiology, with blah, 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 neurology, et cetera, et cetera? Very possible. And hopefully IHS is going that way. So I don't know though.
Absolutely. And Dr. Taranella chimed in from the Portland area that that's something that is being thought about and looked at in that space as well, specifically because of what Dr. Ritchie said about the volume challenge. And if you can consolidate that volume just across the entire country or the entire agency, that would overcome that barrier. But the critical first step is showing that it's a viable enterprise. And I think that's really what we've seen out of Chinle, is that this is doable. And again, the space of time that this has been put together in is while everything else has been surrounding you with COVID. And I know exactly how busy Chinle has been in the past 5 months. So thank you all for sharing your experience. Thanks for showing us how doable this is. And we really appreciate your time. So Dr. Ritchie, Stephen Neal, thanks so much for sharing this example out of Chinle. Captain David Wong, thanks for letting us pull you into the conversation. Completely unannounced invitation in the middle of the call. Thanks for joining us. And we're just out of time. So I want to thank IHS headquarters for supporting these sessions each week, to Project Echo for keeping these up and running. And for everyone taking the time to join us from around the country and the many areas. We hope everybody is staying safe and doing well in their regions and their hospitals. Thank you so much for your time today. We look forward to seeing you all next week. We'll be talking about mental health sequela of COVID-19 infection, both for patients who have recovered and also for communities and caregivers. So please join us again next Thursday at 12 Mountain Daylight Time. Thanks so much, everyone, and stay safe.